I can say that iron deficiency anemia and sideroblastic, one is deficiency and one is excess. They are totally opposite. And what was anemia of chronic disease? Pseudo beggar. It's showing me that it's very, very poor, but actually what is happening? Actually, it's having a lot of money in the bank account, and that is why it is not very hungry. That is the final profile table on your last day revision that you should do for the CETA only for the microcytic hypotonic anemias. Now I'm going to move forward and tell you everything about macrocytic. Megaloblastic is what? Megaloblastic is now going to be the macrocytic anemia. And please note, under this macrocytic anemia, now I have to know that megaloblastic is a deficiency. We all know that. It is a B12 deficiency. It is a folic acid deficiency. B12 deficiency means what? B12. Hi everyone, the next chapter of systemic pathology is the central nervous system, with which we will be starting first with the normal cells and what are the variations that they can have. So the first cell, which is the most important, is going to be an astrocyte, and the name itself tells me that it is a star-shaped cell. That's how it's going to look like. And what does it make? We all know it is useful for making the blood. The blood-brain barrier. The same cell can be seen in immunohistochemistry, which basically means that the color that we get is brown, and the immunohistochemical stain for it is GFAP positive, that is glyphosate acidic protein. This is one cell. There's another cell which is important for iron and CT aspirants, and those are the macrophages of the brain, and macrophages of the brain are referred to as microglia. So what are variations of microglia can we see? Number one, the microglia might start looking elongated like this, that is rod, and rod cells are normally seen in neurosyphilis. The next thing is that just imagine what's the work of macrophage anywhere in the body. It is only eating up something. So just imagine that over here there is a nerve that has been damaged. There is a damaged nerve, and where do you think a nerve is going to be damaged? It is either going to be a case something like an infection with polio or infection with rabies, which attack the nerves. So if the nerves have been damaged over here, who is going to come and eat it? The eating up is going to be done by macrophages. So just read the word again: phagia of neurons, eating of neurons. Neuronophagia is one of the things seen in polio and rabies. That's the second variation. Number three is microglial module. What do you mean by a microglial module? It means that all of them is making a cluster. So all of them have decided to make a cluster over here, and that is known as a microglial module. And you see that in HIV positive individuals. HIV finally in the brain is a microglial module. Finally, sometimes they tend to make these small groups, like small globe-like, round globe-like groups. So these globe-like structures are referred to as globoid bodies, and globoid bodies are seen in Krabbe's disease. All of these variations are important for INICET. Done with the cells and the variations, we move on to the next topic, that is neurodegenerative, like Alzheimer's and Parkinson's. Starting off first with Alzheimer's disease, we all know it is a disease which is seen in senile old age after 70 years. Memory loss happens, dementia happens, everyone knows all of that. But do you know there are certain genetic factors as to why Alzheimer's happens in the human population? So the first genetic factor is APP. What is the full form of APP? It is actually the cause of APP, amyloid precursor protein. Do you know amyloid precursor protein is present on chromosome number 21? That is why way back in genetics when we were studying trisomy 21, where there was extra 21 chromosome. I told you that Down's patients, trisomy 21, have premature Alzheimer's. They have more of chromosome 21. If they will have more of chromosome 21, they will have more of APP, and they will end up having Alzheimer's very early in life, that is by 30 years of age. So one gene is amyloid precursor protein. The second and the third gene happen to be PS1 and PS2. The full form of PS is phenylene. You remember it as phenyl, right? So PS1 is going to be present on chromosome 40, and PS2 gene is present on chromosome 1. So the way of learning it is 1 and 1 have to be kept separate. PS1 is not on chromosome 1. Okay, so PS1 is on chromosome 40, PS2 is on chromosome 1. So what is PS for? Boys, I'm sure you are very fond of PlayStation. PS is PlayStation, and PlayStation is a game. So remember that PS1, PS2, whenever there is a genetic problem, which enzymatic activity increases. So if you learned that PS is a game, you will always remember with pre-selenine, gamma secretase. Remember game, gamma secretase activity will increase. There is another gene that is important nowadays, taking up too much of importance and too many questions. ApoE4 mutations. This basically results in early onset. People end up having Alzheimer's early on in their life. So remember APP, PS1, PS2, and ApoE4 for Alzheimer's. Next, they asked you what will you see microscopically. So let me directly show you pictures over here. Over here, you can see one set of pictures which are black and white. One set of pictures are the ones which are going to be like blackish brownish, because remember in the brain, the stain that we tend to use is known as the Weyl-Schofsky stains, passing nuclear, and there's a blackish brown. So the first feature that you see in Alzheimer's is neuritic plaques. What is neuritic plaques? So in the center you're going to have amyloid. In fact, in general pathology, which kind of amyloid gets deposited? A-beta amyloid. So we have A-beta amyloid in the center. And why am I calling it neuritic? Because at the periphery you will see neurites or neurons or nerve fibers like this. So this is what is known as a neuritic plaque. I'm repeating once again. In the center you have A-beta amyloid, and in the periphery you have these nerve fibers or nerve processes. And try to look at the same roundish structure over here. What stain? Weyl-Schofsky stain. So first is neuritic plaques. The second feature that you see are known as NFT, neurofibrillary tangles. Can you see what is the shape of neurofibrillary tangles? On whichever stain you want to look at, they're actually going to look like flame shapes. So your first question is, what are neurofibrillary tangles? They are referred to as hyperphosphorylated tau protein. A very important question for NEET and FLG. Tau protein, and I have always made you remember that you are going to remember your Tau G. Tau G is, for those who don't know Hindi, Tau G is your father's elder brother. So they're probably the eldest in the family, right? Cauchy's Alzheimer's also tends to occur at that age only, 70, 75, Cauchy's age. So remember, tau protein is something you will be linking with Alzheimer's. That's just a... Hi everyone. The next chapter of systemic pathology is the central nervous system, with which we will be starting first with the normal nucleus of the brain. No pictures for Huntington's are required. Coming to the last one for INI CT aspirants is ALS. What is ALS? Amyotrophic lateral sclerosis. In medicine, we get to a question that amyotrophic lateral sclerosis, the same disease that was seen in Stephen Hawkins, was actually an upper motor neuron and a lower motor neuron disease, and the bodies that it shows you are the Bonina bodies. So if I just want to revise the body, in Alzheimer's, the Cauchy-wala hero acting Mirado bodies. In Parkinson's, Park and Lawn are synonyms for Lewy bodies, and in amyotrophic lateral sclerosis, it is going to be Bonina bodies. So with that, you have finished the next topic also, which is going to be the neurodegenerative diseases, and you can start with the last topic, which is going to be the tumors. Before starting with the tumors, it has to be rapid, and at the same time it's going to be a review, which means it's not going to cover the depth of each and every topic in as much as depth as we have studied in our full syllabus or in our full videos, but definitely this is going to include all the important topics with all the high yielding and the PYQs that you need to know for the exam. So let's get going. I hope this is a fruitful journey for all of you, and let us begin with the very first chapter, that is cell injury. I'm going to start off with the first most important one-liners. What is the most common cause of cell injury? Why does it happen? And we all know when the oxygen concentration goes down, that is hypoxia. So the next question will be, why is the oxygen concentration going down? What is the most common cause of hypoxia? And that is when the blood supply is cut off. And what is that condition known as? So when the blood supply is cut off, that is ischemia, and that is when the oxygen levels will go down. When the oxygen levels go down, which is the cell which is most sensitive to hypoxia, which is going to die away very quickly, and those are going to be the neurons, or also going to be the brain tissue. So whatever you wish to call it, they give away basically within 2 to 4 or 3 to 5 minutes. They are going to give away when there is hypoxia. Whereas if they ask you which is the cell which is most resistant, the last man standing, then the answer to that is going to be the fibroblasts. So this is going to withstand even 30, 40, 60 minutes of hypoxia. So these are the first 4 one-liners that you have to know in the cell injury chapter, and the rest of the chapter is going to comprise of what? There are 2 types of injuries that you need to know. Number 1, where everything can come back, that is reversible cell injury, and the second one is going to be irreversible cell injury. So I'm going to start with these, and then I'll go on to the deaths and the adaptations. So when I mean reversible cell injury, you all know there is a mechanism now. You all know there is one flowchart that you have to know. Should we try and make one common flowchart for it? So let's say when I'm talking about reversible cell injury, all of you told me that the story starts off by a decrease in the oxygen. As soon as the oxygen goes down, which is the first organelle which says I give up, and that first organelle is going to be mitochondria. So there is a mitochondrial dysfunction that happens, and we all know mitochondria is the powerhouse of the cell. So the mitochondria gives up. This means the ATP production is going to go down. So what is the previous year question? Which is the first change of cell injury? The first change of cell injury is a mitochondrial dysfunction, and because of this, the ATP production goes down, and now you know that there are 3 changes that are going to happen. So tell me, which is the pump which will stop working? The sodium potassium ATPase pump is going to fail. The sodium potassium ATPase pump is going to undergo failure. So for understanding the failure, you have to know the normal. We all, I think, remember that the normal product called Nokia. What was Nokia? That sodium is going to go out and potassium is going to go in. So we say that there are 3 sodium which are going to go out. So sodium goes out, and there are 2 potassium that are going to come. So potassium comes in. That is how we studied it as Nokia. Sodium out, potassium in. That is normal because that time ATP was there. Now I'm saying ATP is not there. This pump has failed. So now it's going to be opposite. Now 3 sodium are going to enter. Bilkul opposite hoga. Now 3 sodium will enter and 2 potassium are basically going to exit. And that means that because there are more of sodium inside, there is going to be a water influx. A very, very important thing that happens is water influx, also known as cellular swelling. Guys, cellular swelling, why has cellular swelling happened? It has happened because of water. So I call it the hydropic change. Very, very important information. The cell is going to become big like a water balloon. So repeating, because of the failure of the sodium potassium ATPase pump, there is going to be a water influx and there is a hydropic change that happens. Now, as the cell will keep on becoming big, big, big like a water balloon, ultimately there will come a time that there is some breakage that will happen. Water balloon will also burst now, holy pit. We play with water balloon also bursts, and that results in the formation of myelin figures. What are the questions on myelin figures that you're going to get? Myelin figure question number 1, what is it made up of? So it is made up of phospholipid, much more in amount than calcium. The primary concern is phospholipid over here. Little bit of calcium it has. Question number 2, which injury do you see it in? You see it in reversible injury also, and you see it in irreversible cell injury also. But please note, in reversible injury, this process is just going to start, whereas in irreversible cell injury, this process is going to be much, much enhanced. So if there are 5 myelin figures in reversible cell injury, there will be 50 to 100 myelin figures in irreversible cell injury. So basically, this is seen as a part of both cell injuries. Finally, question 3, how does it look like under the microscope? We can all see there are some laminated concretions that I'm noticing, and in these laminated concretions, which microscope have I shown you? The black and white microscope of that, electron microscopy. So these all had resulted because of the failure of the sodium potassium ATPase pump. There is big, big swollen balloon cells, cellular swelling, and there is myelin figure formation. Apart from that, what is the second thing or the second event that is going to take place? Please note, when there is no oxygen, hypoxia, which kind of glycolysis will occur? This is going to result in anaerobic glycolysis. Guys, what is the byproduct of anaerobic glycolysis? It is going to result in lactic acid production. Lactic acid means that the pH of the body is going to go down. When the pH of the body will go down, acidic ho gaya, the lactic acid, what is going to happen to the nucleus? There is nuclear chromatin clumping. That's the next change that is going to happen. There is nuclear chromatin clumping that I noticed. The second change of cell injury. So now I realize that the pump has gone, the nucleus has also gone, only the proteins are left. What is the process that makes the protein? Coming to the third thing. So which organelle makes the protein? Isn't it the rough endoplasmic reticulum? You used to study this in your school, it was also rough endoplasmic reticulum makes protein. What makes it rough? Rough is made by ribosomes. So now I say that in cell injury what happens is that the ribosomes detach. Now guys, if the ribosomes are going to detach, that basically means that the protein synthesis is going to go down, and that is the third change of reversible cell injury. So I've tried to make one common flashcard so you will realize on the rapid review. So most of the places I've got your tables, they got a lot of information written in those tables. Here I did not write that information because I wanted to explain it to you first. But yeah, we're going to have a lot of these flashcards, one flashcard, full topic into it kind of thing, so that the bulk of your subject is reduced. So what happened in reversible cell injury? What are the 3 changes that happen? Number 1, the sodium potassium ATPase pump fails. So there is hydropic change. Along with that, there is formation of myelin figures. Question number 2 is that there is going to be anaerobic glycolysis. So because of the change in the pH, there is nuclear chromatin clumping. And number 3, because the ribosomes are going to detach, the protein synthesis decreases. That is reversible cell injury, because after reversible cell injury, gradually you go into irreversible cell injury. So now if someone asks you, what are the 2 defining moments of irreversible cell injury? All of you are going to say the M and M. What is M and M? The first M basically means when there is a severe membrane defect, or you can say some kind of a membrane damage. And the second one is going to be a mitochondrial damage. What did I say? M and M, membrane damage and mitochondrial damage. So pehle kya karenge? We will damage the membrane. Simple. Let me damage the membrane over here. As I damage the membrane, I realize membrane gone. The barrier is gone. There was a door. I've opened the door. Everyone's going to come inside. I realize the first sorted. Question number 1, what is it made up of? It is made up of. Hi everyone, what is the next cell death that we are going to go to? We are going to start off with apoptosis. Are you ready for it? Hi everyone, give me pump fields. So there is hydropic change, along with that there is formation of myelin figures. Question number 2 is that there is going to be anaerobic glycolysis. So because of the change in the pH, there is nucleochromatic clumping. And number 3, because the ribosomes are going to detach, the protein synthesis decreases. That is reversible cell injury, because after reversible cell injury, gradually you go into irreversible cell injury. So now if someone asks you, what are the 2 defining moments of irreversible cell injury? All of you are going to say the M and M. What is M and M? The first M basically means when there is a severe membrane defect, or you can say some kind of a membrane damage, and the second one is going to be a mitochondrial damage. What did I say? M and M, membrane damage and mitochondrial damage. So pehle kya karenge? We will damage the membrane. Simple. Let me damage the membrane over here. As I damage the membrane, I realize membrane gone, the barrier is gone, there was a door, I opened the door, everyone's going to come inside. I realize the first one to come inside is calcium. Do you know what is calcium going to do? This calcium will go and sit inside the organelle. Which organelle does calcium rush to always? Calcium, this yellow color wala calcium goes and sits in the mitochondria. What is this known as? This is referred to as amorphous densities, or if you want to know the full name of the previous years, it is amorphous flocculent densities. Amorphous flocculent densities. What do you have to know about it? Please note flocculent density. I'll ask you 3 questions and you're sorted. Question number 1, what is it made up of? It is made up of calcium. Question number 2, which organelle are you seeing this inside? This is seen inside mitochondria. And question number 3, which injury am I in? I am now in irreversible cell injury. So where do you see this? You see this in irreversible cell injury. 3 very important points when it comes to this amorphous flocculent density. Calcium in the mitochondria in irreversible cell injury. Super duper important information that you have to know. On that note, this is not the only thing that calcium does. Calcium is also going to go and activate a lot of enzymes. And please note that as it will activate the enzymes, what are the usual enzymes activated? Like phospholipids, proteases, nucleases. Okay, a lot of enzymes are activated. But I am interested in the nucleases. How are the nucleases going to act? That is what is of my concern. So please note that the nucleases cause certain nuclear changes. They break the nucleus of the cell. So what are the 3 steps? You guys have to know this in the exam. It is known as PKK. Pehle to you have to know the order. See, nucleus. Nucleus is something you got from your parents. It can't break like this overnight. Na? It's a step-by-step process. So there is PKK. What is PKK? P stands for pycnosis. Look at this. The nucleus has become so dark and central. So we say there is a nuclear condensation, nuclear shrinkage and condensation that is going to happen. That is what is referred to as pycnosis. Coming to the next. Look at the next change that has happened, guys. The nucleus has broken into pieces. Finally, bomb blast has happened in the nucleus. I refer to it as karyorexis. That is known as karyorexis. Can I just put it up in simpler words? And that is going to be nuclear fragmentation. That is referred to as nuclear fragmentation. And finally, I have the last one, and that is known as the nucleus is gone. It says done. Story khatam. So what is that known as? Karyolysis. See, the word is only telling me lysis means the nucleus is gone. I don't see any nucleus inside this. So if they ask you what are the 3 nuclear changes that are going to occur, there is pycnosis, karyorexis, karyolysis. PKK. Pycnosis means first the nucleus becomes smaller, then karyorexis means it's a blast, and then finally lysis means that it's gone, and that is when we say that the irreversible cell injury is done. So please remember, what were the 2 defining moments? It was M and M. One is membrane damage, one is mitochondrial damage. Membrane damage I can see because of which calcium came in. Mitochondrial damage also I can see because again calcium came in. So either of the 2 things are going to result in calcium injury, and it's going to be super bad. Calcium coming in, super duper bad. That wraps up your story of irreversible cell injury. Going back after this, the next dreadful event is going to be the cell death. So let's get going with the cell deaths. The first one that you have over here is going to be necrosis. Necrosis, apoptosis, necroptosis, pyroptosis. These 4 are very, very important. I'm starting with necrosis. Do you guys remember what was the definition of necrosis? It's a cell death, but what is important is it's a pathological cell death, which means it will always happen with some of the other kind of a disease. Very important. And it is going to be associated with inflammation. There will always be an element of inflammation that is involved. So you will see something like neutrophils written, some other inflammatory cell written. Very important. So these 2 words don't miss out. Necrosis is pathological, but not physiological. It is never going to happen normally. And second, it is associated with inflammation. So let me tell you, what is the most common type of necrosis that we have? That is the coagulative necrosis. Question number 1, this is most common. Question number 2, you will always see this in solid organs. Look at the picture above. You see the picture of a kidney over here, and in this kidney is a solid organ. Can you see this wedge-shaped structure? It's an infarct. It's a coagulative necrosis, an infarct that has happened. So it is seen in solid organs, like it is seen in the kidney. It is seen in the heart. It is seen in the liver. Let me tell you, heart is the most common organ, so you will get a history of a heart attack. My basic concept is all solid organs show you this. Question number 3, what is the mechanism of action? It is said to be the denaturation of proteins. This is a previous year question. The denaturation of proteins is the mechanism of action of coagulative necrosis. Question number 4, what do you see microscopically? So your first point is that the tissue architecture is preserved. Preserved means that everything is going to be just like the way like a ghost. What is a ghost? You will say ghost is, ma'am, that I can see the white color sheet, that outline of a ghost in a Bollywood movie, but I can't see the face of a ghost. So this means broadly some kind of a human being architecture that I can see, but I can't see the details. That is why I say tissue architecture is preserved. Overall, I'm seeing some round structures, but I don't see what those structures Hi everyone. Well, in this module, we would be discussing pathology, but as they say in a rapid, you'll realize in this rapid review, most of the places have got you tables. They've got a lot of information injury because after reversible cell injury, gradually amorphous densities, or if you want to know the on that note, this is not the only thing that calcium does. Calcium is also going to go and activate a lot of enzymes, and please note that as it will activate as pignosis. Coming to the next, look at the next change that has happened, guys. The nucleus has broken into pieces. Finally, bomb blast has happened in the nucleus. I refer to it as karyorrhexis, that is known as karyorrhexis. Can I just put it up in simpler words? And that is going to be nuclear fragmentation. That is referred to as nuclear fragmentation. And finally, I have the last one, and that is known as the nucleus is gone. It says done. Story khatam. So what is that known as? Karyolysis. See, the word is only telling me lysis means the nucleus is gone. I don't see any nucleus inside this. So if they ask you what are the three nuclear changes that are going to occur, there is pyknosis, karyorrhexis, karyolysis. PKK. Pyknosis means first the nucleus becomes smaller, then karyorrhexis means it's a bomb blast, and then finally lysis means that it's gone. And that is when we say that the irreversible cell injury is done. So please remember what were the two defining movements. It was MNM. One is membrane damage, one is mitochondrial damage. Membrane damage I can see because of which calcium came in. Mitochondrial damage also I can see because again calcium came in. So either of the two things are going to result in calcium injury and neutrophil return. Some other inflammatory cell return. Very important. So these two words don't miss out. Necrosis is pathological, matlab not physiological. It is never going to happen normally. And second, it is associated with inflammation. So let me tell you what is the most common type of necrosis that we have. That is the coagulative necrosis. Question number 1. This is most common. Question number 2. You will always see this in solid organs. Look at the picture above. You see the picture of a kidney over here, and this kidney is a solid organ. Can you see this wedge-shaped structure? It's an infarct. It's a coagulative necrosis of infarct that has happened. So it is seen in solid organs. Like it is seen in the kidney. It is seen in the heart. It is seen in the liver. Let me tell you, heart is the most common organ. So you will get a history of a heart attack. My basic concept is all solid organs showing this. Question number 3. What is the mechanism of action? It is said to be the denaturation of proteins. This is a previous year question. The denaturation of proteins is the mechanism of action of coagulative necrosis. Question number 4. What do you see microscopically? So your first point is that the tissue architecture is preserved. Preserved means that everything is action. It is said to be the denaturation of proteins. This is a previous year question. The denaturation of proteins is the mechanism of action of coagulation. Necrosis. Question number 4. What do you see microscopically? So your first point is that the tissue architecture is preserved. Preserved means that everything is going to be just like the way, like a ghost. What is a ghost? You will say ghost is, ma'am, that I can see that white color sheet, that outline of a ghost in the movie, but I can't see the face of a ghost. So this means broadly some kind of a human being architecture that I can see, but I can't see the details. That is why I say tissue architecture is preserved. Overall, I've seen some round structures, but I don't see what those structures have. So basically, these are known as ghost cells. These are referred to as ghost cells. So a ghost cell ka definition, the outline is going to be preserved and the details are lost. The details are lost. That is what you understand. Graveyard जैसा लग रहा है. That basically means that I am dealing with a tombstone appearance. I am dealing with a tombstone appearance. Repeating once again, this is the most common type of necrosis. You will see it in all kinds of solid organs like kidney, liver, and heart. Heart is very common. Denaturation of protein is its mechanism of action. Tissue architecture is preserved. You see ghost cells and tombstone appearance. Coagulative necrosis is done. Repeating once again, it is going to be seen in the solid organs, except it is not seen in two solid organs. So please note. Now when I give you the example of the brain and the pancreas, now when I give you the example of the brain and the pancreas, these are also solid organs, but they don't show coagulative necrosis. They are going to show liquefactive necrosis. And the other name for liquefactive necrosis is going to be colliquative necrosis, because the word is only telling me that liquid liquid. Something is going to get liquefied, and I can see that over here. There's a lot of liquid material. This is a section taken from the brain, as you all can see. This is the only picture of liquefactive necrosis that they have in the segment of the brain. So did you notice or try to ask me that why, ma'am, will all the solid organs be showing coagulative, why these two are showing liquefactive? Because these two are the organs which are very, very rich in hydrolytic enzymes. These are extremely rich in hydrolytic enzymes. So you have to know this, and that is what you know for brain and pancreas. If you get a history of pancreatitis or if you get a history of a stroke, this is the necrosis that you're going to see. Liquid, solid to liquid. So what do you say? Is the tissue architecture preserved? No, the tissue architecture is not preserved. The tissue architecture is not preserved because now something is going to become liquidy over here. These two necroses are done. Club the two. Coagulative or liquefactive ka mixture kar do. What are you going to get? The third one, which is the most common in our country, the mixture of coagulative necrosis and liquefactive necrosis, that is caseous necrosis. However, question 1, which is the more commoner necrosis? So C for C, coagulative necrosis is the more common one that you see in caseous. Question 2, what is the meaning of caseous necrosis? This everyone knows since first year of MBBS. Caseous means cheesy, so you're going to see some cheesy white, nice cheesy white, and cheesy blooming for a lifetime because cheesy material is what you see on a caseous necrosis. Okay, so now what are the conditions in which you're going to see them? Of course, in our country, the first thing coming to my mind is tuberculosis, but this is also seen in fungal infections. Please note, they will give you an example of a fungal infection, for example, histoplasmosis. They could also give you coccidioidomycosis. So all of these fungal infections is what they are going to mention. They all show you the presence of caseous necrosis, the cheesy appearance. Okay, on that note, before I move on to the next necrosis, we want to try solving a question to see whether you're on the right track. Have a look at this. So this rapid review will just because now something is going to become liquidy. Question 2, what is the meaning of caseous necrosis? This everyone knows since first year of MBBS only. Caseous means cheesy, so you're going to see some cheesy white, nice cheesy white, and cheesy blooming for a lifetime because cheesy material is what you see on a caseous necrosis. Okay, so now what are the conditions in which you're going to see them? Of course, in our country, the first thing coming to my mind is tuberculosis, but this is also seen in fungal infections. Please note, they will give you an example of a fungal infection, for example, histoplasmosis. They could also give you coccidioidomycosis. So all of these fungal infections is what they are going to mention. They all show you. The presence of caseous necrosis, the cheesy appearance. Okay, on that note, before I move on to the next necrosis, we want to try solving a question to see whether you're on the right track. Have a look at this. So this rapid review is me being a little breathless and teaching you a lot of things in a very short manner, but also making you practice questions. So here you have a 61-year-old female who presents with left-sided chest pain. I've started making a history in my mind, which is also radiating to the arm and the jaw. The pain is increased severely over the past 40 minutes. The patient is immediately rushed to the hospital. cardiac enzymes are elevated is a very important history mention. Patient is admitted and started on thrombolytic therapy. However, on the 5th day of observation, the patient collapses and dies. What did you make this as a case of? Classical case of myocardial infarction. That means I'm dealing with a solid organ. They've asked me what is the necrosis that you see in the heart. I know the necrosis that we see in the heart or any solid organ is going to be the coagulated necrosis. So the answer becomes so simple over here. How they started off with a medicine question, how they landed up with a regular general back question. So coagulated done, liquefactive done, gaseous done. Now I move on to the next one, and that is the fat necrosis. So please note, this is the easiest for me because it is to do with fat. So what are the examples that I'm going to get over here? Either I'm going to get the example of breast because breast contains fat. So breast may you will say why is fat breaking down? Fat is dying because of trauma. Fat is dying because there is some injury, road traffic accident on the chest, there is an injury, some football hit on the chest. That kind of injury to the chest is going to break the fat. So fat breakdown, fat death will happen because of trauma. Second situation can be momentum. Why do you think in the momentum, GIT momentum, why is fat breaking down? This is due to pancreatitis. Why? Because in pancreatitis, which enzyme is released? In pancreatitis, there is an increase in lipase, and don't you think that lipase is going to break the fat? Yes, so either it is seen in the breast or it is seen in the momentum. Why is fat breaking down? In the breast because of trauma, in the momentum because of pancreatitis. Whatever may be the situation, the fat that is going to break down is going to break down into fatty acid and calcium. And how does calcium look like? All of you know this, taking you back to school days, that when fat will break down into fatty acid and when calcium will come and stick to it, calcium is going to look like a chalky white area. Calcium is going to look like a chalky white area. So simple, starting deco, ending deco. If I have to pick up a case of fat dying or fat necrosis, what areas am I going to pick up? I'm going to pick up these chalky white areas, and that is going to make all the sense over here. So remember, fat necrosis, I'm going to show you chalky white area. Sorted. The fourth necrosis is also done. Let's go to the fifth one. What is the fifth one over here? Fibrinoid necrosis, one of the easiest, because whenever some antigen antibody complex formation will occur, fibrinoid necrosis will occur. We are going to do it in a very simple manner. All the 3-letter things are going to be examples over here. So what is PAN? Polyarthritis nodosa. What is RHD? Rheumatic heart disease. Everyone knows from the cardiac chapter that rheumatic heart disease is going to show you something known as the ash of bodies, है ना? So they indirectly show you fibrinoid necrosis. So PAN. RHD. Then you have an autoimmune disorder called SLE. Then you have hypertension written as HTN. But which hypertension? It is usually malignant hypertension. So all these PAN, SLE, RHD, HTN, all these three-letter things are going to show you fibrinoid necrosis. And the picture seen over here, if you know the organ, you know the disease. The organ is blood vessels. And I can see there is a band of pink color, fibrinoid necrosis, that I'm seeing over here. So now tell me something that fibrinoid necrosis in the blood vessel makes it what? It makes it a case of polyarthritis. Nodosa. So the fifth necrosis is also done. Coming to the sixth and the seventh, whatever you studied up till now were all pathology diagnosis, were all pathology necrosis. Now I'm starting with diseases which are clinical. What do you mean? It makes it a case of polyarthritis. Nodosa. So the fifth necrosis is also done. Coming to the sixth and the seventh, whatever you studied up till now were all pathology diagnosis, were all pathology necrosis. Now I'm starting with diseases which are clinical. So here you have a case of gangrene. Gangrene is what? Gangrene is a clinical diagnosis. The clinician or the surgeon is going to tell me that okay, this is a case of dry gangrene and this is a case of wet gangrene. You can see dry gangrene is everywhere, dry or wet. What you can see is it's a very, very blackish tissue which is foul smelling. That is the definition of gangrene. It is black, foul smelling tissue that has occurred. And dry gangrene and wet gangrene are simple. Let the surgeon know these terms because for me, जो dry lag रहा है, and dry gangrene is nothing but coagulative necrosis, and this wet gangrene that you have is nothing but liquefactive necrosis. So coagulative necrosis and liquefactive necrosis are nothing but dry and wet. So kind of making sense now. Dry is coagulative and wet is something liquidy. So liquidy matlab liquefactive necrosis. So basically I say gangrene is, this is the people like you way long back 7-8 years old came. Gangrene is a clinical term, not a pathology term. Sorted. There's one more clinical term. There is something known as Zenker's degeneration. What do you mean by that? So firstly, again, just kill it is nothing new. This is nothing but a type of coagulative necrosis. It is a type of coagulative necrosis. So why is it different? Because this is seen in typhoid patients, salmonella, typhoid killed the typhoid is food poisoning. No? So you say now Zenker's degeneration of food poisoning? No. It is seen in typhoid. It is a type of coagulative necrosis not occurring in the intestine. No, it has nothing to do with food poisoning. It is to do with skeletal muscle. This is a necrosis that has happened as a complication in the skeletal muscle. And two very important muscle groups that are affected are rectus abdominis and diaphragmatic muscle. It is rectus abdominis and diaphragmatic muscle. These are the two groups of muscle which are very commonly affected with Zenker's. So these are the three PYQs of Zenker's that you got. Number one, it is a type of coagulative necrosis, so it's nothing new for us. That's question one. Question two, it is seen in typhoid, and question three, it is seen in organs like skeletal muscle. And that wraps up your entire discussion of necrosis. Hi everyone. What is the next cell death that we start off with apoptosis. Are you ready for it? Because I'm going to tell you differences. I hope your rapid review is going well till now. When I talk about apoptosis, I think the definition that you have been taught since first day of MBBS they started. What is apoptosis? Apoptosis is known as programmed cell death. Everyone will remember it till we die. We know this programmed cell death. But now that definition has an update. This programmed cell death is said to be a caspase-dependent programmed cell death. And does it have inflammation? That is what differentiates it from necrosis. Necrosis means cell was rupturing. There was inflammation present, whereas apoptosis is not going to have any inflammation. It is a programmed cell death which is dependent on a lot of caspases. So now the first thing that you will ask me is this seen normally or in diseases or both? Because you had studied that necrosis jo hai, that is only seen in diseases like TB or heart attack or stroke or pancreatitis. Necrosis was only seen in diseases, means necrosis was only pathological, but apoptosis is both. Apoptosis is going to be pathological as well as physiological, means they will ask you name one example of physiological apoptosis. Whereas what is it about pathological apoptosis? They always ask you these two C bodies, so always listen to me carefully. Always remember there is something called Councilman bodies, and then there is something called civet bodies. These two bodies are seen in some diseases, so they are pathological. Councilman body, C for C, it is seen in viral hepatitis. Kaunsa wala viral hepatitis? It is seen in most commonly with hepatitis C virus. So Councilman bodies are seen with hepatitis C virus, viral hepatitis. Whereas civet bodies are given a lot of other C names. They are known as colloid bodies. They are also referred to as the cytoid bodies. So a lot of C names have been given to them, and they are seen in a condition which is known as LP, lichen planus. So you guys, when you go back to lichen planus, do you remember in dermatology that has Wickham's try, and it is planar, polygonal, plaques, papules, pruritic, Yes, purple, that PP lesion in dermatology. I hope you all remember. When you go to dermatology, you will get this question. वो PP वाला जो lesion है, that is lichen planus, has a very important body known as the colloid or the civet or the cytoid body. So देखो, once again, if someone asks you what is councilman body, it is apoptosis. What is civet body, it is apoptosis. It is a pathological apoptosis. I hope everyone understood this. And coming back, this was nothing but a caspase-dependent program said. So next question that they will ask you is what is the mechanism of apoptosis and how are you fitting the caspases into it? So please remember, in the mechanism of apoptosis, we have two ways. First, you have to start apoptosis, initiate, and then you have to execute apoptosis. So what did I say? What are the two things that we are studying? You have to start apoptosis and then you have to execute it. So when I say that we are starting apoptosis, either you will start it from outside, extrinsic pathway, or you will start it from inside, that is intrinsic pathway. So repeating, either from outside or it is going to be from inside. So कैसे याद करें? Please remember that we have something called caspases in this entire process. So for initiation, I have caspase 8, 9 and 10 in order. For caspase 8, 9 and 10 for initiation, and caspase 3, 6 and 7 we have for execution. First, you please ratta lagao mangeter. Caspase 8, 9, 10 for initiation, caspase 3, 6, 7 is going to be for execution. And please note, out of 8, 9 and 10, देखो नवीन write extrinsic pathway. Extrinsic pathway sounds like 8 and 10. E for 8 and X for 10. So in the extrinsic pathway, caspase 8 and 10 are going to be activated. In intrinsic, if you read it opposite, it sounds like 9. So caspase 9 is going to be activated. Repeating, caspase 8 and 10 in extrinsic, and caspase 9 is going to be in intrinsic. Whereas for execution, it is going to be 3, 6 and 7. So did you notice what exactly is a caspase? This is a question that you get. What is cas, ASP and ACE? Very important. So question number 1, what is C for caspase is standing for? This means it has cysteine residues. Caspase has cysteine residues. Coming to the next, what is ASP? ASP is going to be aspartic acid. What is this? What about aspartic acid? So remember, A is क्या है? A is मतलब enzyme. So at the end of the day, caspase is an enzyme. Enzyme means it's going to break something. How is it going to break? It is going to break the tissue after it sees aspartic acid. So for example, if this hand of mine is a tissue, you say, ma'am, I see aspartic acid on this finger, I will break it here. Then I see aspartic acid on this finger, I will break it here. Then I see aspartic acid on this finger, I will break it here. So wherever it will see aspartic acid, break, break, break. That is how it works. So remember, question 1, C for cysteine residues, ASP for it breaks after aspartic acid, and AS means it's an enzyme. So caspase 8, 9 and 10 for initiation, 3, 6 and 7 for execution. We're going to give 5 minutes and quickly revise the mechanism. So first, I'm starting with initiation and we're starting with the extrinsic pathway. So please note, extrinsic pathway means something is happening from the outside. So for example, this is the cell which has to undergo apoptosis. This cell is blessed with something called CD95 or FAS. Remember, CD95 is the molecule. And this is the cell that I got from my system. Guys, remember, this is a T cell of your body. This is a CD8 T cell. And this has something called CD95 ligand or FAS ligand. It has CD95 ligand or FAS ligand. That is what it contains. So please remember, bahar, from outside, the interaction is occurring. So this is an extrinsic pathway. When they will combine, there will be 2 more molecules of CD95 that will come. So now how many molecules of CD95 are there? There is going to be trimerization. There is a trimerization of CD95 that is going to occur. And as soon as they become a trio, they feel we have become so powerful. Let us get another very powerful molecule. They get something called FAD. Now they are going to attract a very big powerful molecule called FAD. And you know what FAD does for you? FAD is going to activate which caspase? If there is an extrinsic pathway, which caspase will you activate? FAD is going to convert pro-caspase 8 and 10 because extrinsic pathway here into caspase 8 and 10. That is important. So remember, this was outside. Let me ask you some questions. If I tell you to put it in the correct order, first there is a one-on-one interaction. CD95 and 95 ligands. So 95 and 95, 95 ligand, one-on-one. Then CD95 says, मुझे trimer बनाना है. So 3 of them are going to come. First there was one-on-one interaction. Then there's going to be a trimerization that will happen. After the trimer is formed, they're going to get a big molecule called FAD. And pro-caspase 8 and 10 will be converted into caspase 8 and 10. So extrinsic 8 and 10 have been activated. But is there any molecule which can stop this process? This process can be stopped by something called flip. So when we are asked what is flip, definitely you're going to tell me that flip is an anti-apoptotic molecule. Because as I said, it can flip the story. It can stop all of this from happening. Which pathway was this? This was, guys, the very famous extrinsic pathway. Now we are still in initiation and I'm going on to the intrinsic pathway. What is it about intrinsic pathway that you have to know? Something is going to happen inside the cell. So for example, if this is a cell, I am saying some element of stress has come. So for example, there is a UV light, sunlight stress that has come into the cell. As soon as it comes into the cell, it is going to activate certain stress sensors. I call them like those fire alarms. They start ringing that some stress has come. And what are those fire alarms? We have bim bid bad, noxa puma. Like I said, learn it the same way because it rhyme bun jata hai. There is a bim bid bad, noxa and puma. These fire alarms start ringing. What are they going to do? When they start ringing, they will say, I'm going to stress, remove any stressful cell in the body, stress hatao, remove this cell. They are going to increase all of your pro-apoptotic molecules and they are going to decrease all of your anti-apoptotic molecules. So what are they trying to do? They are trying to take you towards killing, towards apoptosis. That stress hai, cut the stress, remove the stress. So in the exam, they are going to ask you, what are all the pro-apoptotic molecules and what are all the anti-apoptotic molecules? So please note, pro-apoptotic, I'll tell you a list and then I'll tell you one mnemonic. Okay, good deal. Pro-apoptotic, we have B53, we have BAC, we have BAX, we have BCL-XS. Whereas anti-apoptotic, we have BCL2, MCL1 and BCL-XL. And how am I going to learn it? Anti-apoptotic means it is going to lower. Lower means L. All the LL containing things means you have BCL2, you have MCL1, so you have BCL-XL. Repeating, BCL2, MCL1, BCL, not XS, XL. All these LL things are going to lower apoptosis. They are going to be anti-apoptotic. apoptotic. ठीक है, याद हो गया? So what have I done? And everything else that you have, P53 bags, BCL, XS, they are all stimulating. They are pro-apoptotic. ठीक है? So now coming back, what are you doing? You are increasing all this pro-apoptotic molecule. You are decreasing all these anti-apoptotic molecules. As a result of which, what is going to happen? You are going to send a signal to the, what is this organelle? This organelle is the mitochondria. You are going to send a signal to the mitochondria that please kill the cell. Just kill the cell. Mitochondria says, wait, I will release two things and that will kill the cell. Number one is something known as SMAC and DAB. SMAC and DAB are going to kill the cells. Number two is going to be cytochrome C. When they ask you, how does cytochrome C kill the cell? Cytochrome C combines with something called APAF1 and together they are known as apoptosome. This is a previous year question. Keep noting all these PYQs that I'm telling you, it will help you. Cytochrome C is going to combine with APAF1 and they are going to together form an apoptosome. That apoptosome will finally convert the famous pro-caspase 9 into caspase 9 because if you remember which pathway are you in? You are in the intrinsic pathway. In the intrinsic pathway, which is the caspase that you have to activate? 9. So finally, the question that you get, what is the apoptosome made up of? Apoptosome is made up of cytochrome C and APAF1 together they are called an apoptosome and they are going to finally activate caspase number 9 and I realize that with this process your initiation is done. The extrinsic is also done, CD95 wala part hai, and intrinsic is also done. Once initiation is done, 8, 9, 10, everything has been activated. Now it's a chain reaction. Now you're just going to do execution. So please remember, if caspase 8, 9 and 10 all have been activated, now they are going to go and activate caspase 3, 6 and 7 and that is what is execution. How simple. Now it's a chain reaction that has started. Execution is done. You're like, ma'am, the apoptosis is over. No, one tiny little step is left. You know, initially you had such a big cell and such a big nucleus and then you had chota ribosomes and endoplasmic reticulum and mitochondria. Is it so simple that suddenly I say caspase 8, 9, 10, 3, 6, 7 and some diagram? Now, what is going to happen is the cell is going to fall off in bits and pieces. There are going to be membrane-bound organelles. There are going to be membrane-bound organelles which are going to fall off. They might fall off with the nucleus, they might fall off without the nucleus. Both is possible. So for example, there's a piece which falls off like this, little bit without the nucleus. There is a piece that falls off like this with the nucleus. So it could be with the nucleus or without the nucleus. Both of those are possible, right? And please note that these are referred to as apoptotic bodies. Now imagine you have thousands of apoptotic bodies circulating. What are you going to say? These apoptotic bodies are then going to go and send a signal to the macrophages. These apoptotic bodies, they are going to go and send a signal to the macrophages that please, what is macrophage? Macrophage is a hungry cell, that please come and eat me and finish. Macrophage is going to cause phagocytosis and finally your cell is completely demolished. That is apoptosis. So now, is it so simple? How did the apoptosis send a signal? What is this signal that they are talking about? What signal? How did it call the macrophage that please come and eat me? That is known as a very important step called flipping of phosphatidylserine. Apoptotic bodies are going to do a flipping of phosphatidylserine as a result of which there is a signal. PS likhte hain. Phosphatidylserine is PS. You get a signal that there will be flipping. So for example, if this is a cell, it will bring the phosphatidylserine outside. It has got the phosphatidylserine as the marker. It's called the sign of the phosphatidylserine. This is also known as this step that I've just explained, that how the phosphatidylserine is flipped and how the macrophage goes and eats it. This process is also known as efferocytosis. This is also referred to as efferocytosis. This is also known as eat me signal. Getting the phosphatidylserine outside is nothing but the eat me signal, right? They are giving a signal, no phosphatidylserine, this is not going to eat it. So phosphatidylserine is an eat me signal. Very, very important. I hope everyone analyzed this because apoptosis is done and I'm going to give you a 30-second quick recap once again. Apoptosis was of two types, physiological as well as pathological. Pathological with those C bodies you have to learn, council and activate bodies. Now we talk about mechanism. First you start initiation, either it's by the extrinsic pathway where you activate 8 and 10 caspase, or it's by the intrinsic pathway where you activate 9. Once 8, 9, 10 is activated, you go and activate 3, 6 and 7 caspases, means you've done execution. When execution is also done, you will realize that the cell will start breaking off into bits and pieces known as apoptotic bodies. How will you convince apoptotic body? You will call, you will send a signal to whom? You will send a signal to the macrophage. How do you send a signal? You send an eat me signal. Flipping of phosphatidylserine happens and that is also known as efferocytosis. Macrophage will come, will eat it and the story is finished. If someone now asks you, what are you going to see under the microscope and what are going to be the markers? So please know, look at the nucleus of an apoptotic body. This is apoptosis. So there are 3 parts that you have to know. Very, very important. When they ask you what is the microscopic feature of apoptosis, the cell is going to become shorter. There is going to be cell shrinkage. The size is going to be smaller, but the colors are going to be very enhanced. There is going to be an extremely pink color cytoplasm that I noted. notice. And there's an extremely blue color nucleus that I'm noticing. And this is important because do you see why is the nucleus extremely blue? Because this is due to NCC, nuclear chromatin condensation. Please note this is due to nuclear chromatin condensation. Very, very important phenomenon. The chromatin is condensed. Nuclear chromatin condensation, and that is you can see on this electron microscope picture. You can see जो black areas है, these are the areas in which the nucleus is basically condensed. So repeating once again, if they ask you what is going to be the microscopic examination and what is going to be the hallmark of apoptosis, all of you will say it is nuclear chromatin condensation. That is the hallmark. If they ask you what is the marker, the marker is annexin 5. The marker is annexin 5. And please note, there are certain other annexins also. So if the examiner says annexin A1, annexin 5, why do you not get confused? Because apoptosis is AP. AP means annexin penta. Annexin penta. So apoptosis will tell you annexin penta. And guys, where do you see annexin A1? वो भी बता दूं. Annexin A1 is seen in hairy cell leukemia. It is seen in hairy cell leukemia. So hairy cell matlab A1. That is how I notice it over here. It is seen in hairy cell leukemia, whereas annexin penta is seen in apoptosis. Easy to learn. That is the marker. But what is the molecular marker? Molecular word means some CD95. Na? Some CD marker matlab molecular. So CD95 is the marker that I use over here. Next, I need to know that is there any stain which is important? Yes, there is a staining procedure called the tunnel stain. Please note that tunnel stain is actually going to be positive or negative. Tunnel meaning the staining is always positive or negative. So if you get a positive tunnel stain, you are dealing with the case of which cell death? You are dealing with the case of apoptosis. And if you have a negative tunnel stain, this means you are dealing with the case of necrosis. And how are you going to learn it? Positive has PO, apoptosis has PO. Negative has NE, necrosis has NE. So it is negative in necrosis and positive in apoptosis. That is the tunnel staining. Lastly, we have gel electrophoresis. Now, what is gel electrophoresis that you all have to know? Have a look at this very, very famous picture. This is DNA gel electrophoresis. This is the DNA totally intact of a normal person, not broken at all. This is normal DNA. Here I see the DNA is broken into many, many lines. And what is this known as? This is known as the step ladder pattern. Where do you see the step ladder pattern? Most commonly it is seen in apoptosis. It can be seen in necrosis also. Can be seen, but most commonly it is seen in apoptosis. Coming to the next, what is this pattern known as? This is known as the smearing pattern. When I'm saying smearing pattern, this is something that you see in a case of necrosis. Repeating once again, if I ask you the step ladder pattern, this is obviously very, very obvious. So step ladder pattern most commonly seen in apoptosis, can be seen in necrosis too, whereas smearing pattern is seen most commonly in necrosis. So please remember this DNA gel electrophoresis, much expected question, very, very important. So if I ask you a question like this, which says that the following gel electrophoresis pattern in patient B. In patient B means this patient, what is this pattern showing you? It is the step ladder pattern. What do you see it in? Necrosis, apoptosis, both or none? Come on, we would want to mark apoptosis, but there is an option of both present. And that is why my best answer over here shall obviously be both. Both matlab, it is going to be seen in both necrosis as well as apoptosis. If I were to select only one thing, I would have selected apoptosis. But you know the both is, so I will select both. So that wraps up your necrosis and apoptosis. What are you going to move on to next? Quickly, you will study the newer cell deaths. Under the newer cell deaths, I want to teach you necroptosis and pyroptosis. Let me start. When I say necroptosis, of course, this is going to be a combination of two things. It is a combination of necrosis as well as apoptosis. Now, when I say necrosis plus apoptosis, so little bit of necrosis it will have, little bit of apoptosis it will have. You guys have to tell me the definition. Do you know necroptosis is a kind of a programmed cell death? You will say, ma'am, apoptosis was also programmed cell death. Difference kya hai? This has nothing to do with caspase. This has nothing to do with caspase. It is a caspase independent programmed cell death. That's the word that you cannot miss in the paper. It is a caspase independent. I promise, I will not talk about caspase at all over here. What are the causes? Missing of Pathological, please remember, this is now being associated with fatty liver. Fatty liver means steatohepatitis. This is also being associated with pancreatitis. So these are the diseases in which necroptosis is occurring. What is the last part that you have to know? Jaldi se mechanism ki kar lo. Means you have kind of the mechanism. One thing that I know that I never can use the mechanism is cascade. Never, ever, ever. Listen to me a million times. Necrosis and apoptosis are common. That is necroptosis. Never, ever, ever use caspases. So what is the mechanism? 1, 2, 3 death. That is how my students learned in previous lectures. Necroptosis means 1, 2, 3 death. What is 1, 2, 3? The first thing is the binding of TNF with TNF receptor. That is the first step that happens. As soon as the TNF and TNF receptor bind, there is a trio formed, and that trio is RIP kinase 1, RIP kinase 3, and pro-caspase 8. And suddenly you're like, ma'am, abhi to you had said like promise, I will not use caspase, and never, ever, ever will you use caspase. And you yourself are mentioning, but listen, I kept my promise. I am not mentioning caspase. I am mentioning pro-caspase. Pro-caspase 8 can be used. Caspase nahi hoga. Inactive is used. Active is not used. Caspase is not used. So I kept a trio of RIP kinase 1, RIP kinase 3, and pro-caspase 8. And this is the Roberts 10th edition update. This is going to result in MLKL phosphorylation, and that is how finally the death is going to occur. So a simple question comes that which cell death shows you MLKL phosphorylation? It is necroptosis. 1, 2, 3 death. 1 matlab TNF receptor. Second, there is a trio called RIP kinase 1, 3, and pro-caspase 8. Finally, there is MLKL phosphorylation, and the cell is going to die. This can occur normally, like in case of growth plate formation. It can occur in diseases like fatty liver and pancreatitis. Done with necroptosis. The next cell death that you have is going to be pyroptosis. Then I need to practice questions. What is pyroptosis telling you? Pyro. What is the meaning of the word pyro? Come on, pyro means fever, something. Bacteria, virus, kuch hoga. Some fever thing is going to occur. Yes, this is actually associated with some kind of a bacteria. Very commonly in the paper you will get questions of salmonella, shigella, these kind of bacteria. When the bacteria, so for example, I draw a bacteria over here. When this is a bacteria and this bacteria enters into the body, can you say that which is the receptor that is going to welcome it? Which receptor welcomes the bacteria? That is the question that you get. The NOD2 receptors. The NOD2 receptors are going to welcome and receive this bacteria. And you know what is going to happen after that? There is going to be activation of inflammasomes. There is activation of inflammation. Na? Bacteria aaya to inflammation. There is activation of inflammasomes. And which caspases are going to come under this process of activation? Caspase 1, 4, 5, 11. Repeat with me 1 million times. 1, 4, 5, 11. That's enough. What are the caspases involved in pyroptosis? It is going to be 1, 4, 5, 11. So please note, out of these, pyro fever भी होगा, pyrogen भी होगा. So please note that this caspase 1 is going to go and activate interleukin 1. Caspase 1 will activate interleukin 1 and this in turn is going to result in fever also. So we ask you a simple question. What are the caspases that cause cell death? 1, 4, 5, 11. But which caspase causes fever? 1 for 1. Caspase 1 is going to activate interleukin 1 and that is going to cause fever. Because we all know interleukin 1 causes fever and that wraps up your pyroptosis. Are you ready for some question? Let's do a question first on necroptosis. Let me ask you which of the following is incorrect about necroptosis. Incorrect पूछा है, ठीक है. Is it a caspase independent programmed cell death? बिल्कुल correct. Done. Does it use RIP kinase 1 and 3 complex? बिल्कुल correct. Does it have bronch plate formation? Physiological necroptosis, correct. But tell me, does it have caspase 8? No, the rule was, I said na, never necroptosis will never ever. Whatever. Caspase 8 is never ever used. Pro caspase 8 can be used, but caspase. This is not used, and that is the answer over here. Let's practice one more question and wrap up the cell deaths. Which of the following is incorrect about pyroptosis? Tell me. Pyroptosis is seen with bacteria like Salmonella, Shigella, and this. Is caspase 1 required? Of course, death के लिए, fever के लिए caspase 1 was required. Was interleukin 1 you.